Thank you so much. So next, last but not least, we have Sanjeeva from Oxford University, and he's going to talk us about the Transpetrous Transtentorial approach, and then we will be over and we'll wait for you tomorrow. Sanjeeva, it's your moment.
Thank you very much, Pablo. Can you hear me okay there?
We can.
We hear you, Savi.
Great. And can you see my screen?
Yes, we can.
Perfect. Thank you very much, Imad and Vlad, for the invitation. I think it's been a very good day. I've learned a lot myself from these talks, so it's been excellent. One person we really have to thank, who did a huge amount of hard work here, was Pablo, who fixed a lot of the problems, did a lot of work to make this session. So if you enjoyed this, which I'm sure we all have, Pablo, thank you very much for a lot of hard work to make this happen today. And well done on all of that. I'm going to talk today about the Transpetrous Transtentorial approach. And I'm sorry, Imad, I'm not really going to talk about the anterior petrosectomy. It's only going to be mostly the posterior petrosectomy. This is an approach that I think is very helpful. Oh dear, I'm having the same problem as Salman and I can't move forward. Here we go. Okay. This is an approach that I think is incredibly helpful for coming around for lesions in front of the brainstem. And these are just some of the tumors or lesions that we would treat using this approach. So you can see when you have very large and what might be very tough tumors, although equally you could come retrosigmoid, but if you think it's going to be challenging, you could look to use this Transpetrous Transtentorial approach. If you think the plane is going to be poor, and it can be in some of this, the PIA is involved, you've got cystic changes within the brainstem, or you're seeing a very vascular and very large tumor, or even a tumor here on the far right. We didn't do all of this, but we used it as part of a combined approach. But you can see how both cavernous sinus, both carotid arteries, the basilar brainstem are all involved by this. This is a very good approach. So these are the types of things you could look to use this approach. So as I said, it's for lesions that are anterolateral to the brainstem. I use it a lot for petroclival, chondrosarcoma, schwannomas. I team up with my vascular colleagues and we go for brainstem or basilar trunk lesions as well. So before we go into the approach itself, I think it's very important to talk about the posterior fossa. And you have to understand that the posterior fossa is a cone like this, and you have to understand which approach gets you where in the posterior fossa. And I know Imad sort of touched on this already. So the first thing you think of course, when you're coming to the top is you're thinking of the Kawase here shown. And usually for me, and I know, depending on how much drilling you do, some people view this differently, but for me, if you're above, if it's a tumor above the IAM and going to the petrous apex, then yes, the Kawase is a very reasonable approach to use. And I really wouldn't use it for anything going lower than the IAM. If the retrosigmoid, of course, is the workhorse approach. For most pathologies, at least once a week, we're probably using the retrosigmoid approach to go into the CP angle and get lesions or tumors in that area. And of course, when you're lower down around the foramen magnum, you're then looking for the far lateral approach. But today, we're going to talk about essentially using the posterior petrosectomy. So coming, through the petrous, cutting the tentorium. And we're really looking for this Transpetrous Transtentorial approach that really shifts us around, coming around the front of the brainstem to get to lesions more anterior there. So what are the components of this approach? So usually what you do is you'd have a middle fossa craniotomy. And then as we're going to see, we're going to pick one of the various, pre-sigmoid approaches, whether you're going to pick a retrolabyrinthine approach, a translabyrinthine or a transotic approach. And then you're going to cut the tentorium. And that's what's going to give you this nice view coming around the front of the brainstem. And what is the aim of doing this? What does this give us beyond a standard retrosigmoid approach? So what you're really trying to do is expand your surgical corridor. So if you have particularly high lesions, like this one here is actually going higher up. You get really good working angles on either side of the fifth cranial nerve, as we'll see later in the video, that you can really work on either side of the trigeminal. You've got this nice view above the tentorium. You pick up the cranial nerves very early or really further forward around the cerebellum. And usually the vessels, you see much later. That, of course, has its pros and cons. Same with seeing the cranial nerve early, that's got its pros and cons. And that's different to some of the endoscopic approaches that would be taken where you get to the cranial nerves very late. And of course, it obviates the need for a Silvan fissure splitting, which can also be used for some of these higher lesions. So let's just talk about some of the other options again. I'm advocating, when you're coming around the front of the brainstem, that you use this sort of transpetrosal, but equally a retrosigmoid is very reasonable. Some people, as I was talking earlier with this unlocking, you could then drill and drill low down, but for me, I wouldn't go lower than I am, but of course, there are surgeons who would. You could looking to do an OZ, splitting the fissure, even taking the anterior temporal veins and doing this pre-temporal approach, or a sort of approach through the cavernous sinus, which again will take you very nicely lower down. And of course, nowadays, there's the endoscopic approach, which is excellent for dealing with a lot of these tumors, particularly these softer tumors in front of the brainstem, and sometimes we would combine these approaches. Okay, so let's say you're going to do one of these cases, and as we've heard from a lot of speakers today, you have to really study the imaging. And for most skull-based pathology or extrinsic tumors, it's really about understanding the venous anatomy. The one vein, and of course you must try and protect all of the veins, but the one vein, of course, that is extremely unforgiving is the vein of Labe. Any sort of injury there is going to have severe consequences. So protecting the veins is key, especially the vein of Labe. It's useful to understand the transverse and sigmoid sinus and their dominance and how large they are, because you're going to have to be working against them to a degree in a lot of these pre-sigmoid or transpetrous approaches. Understanding how high the jugular bulb is important. You can lower the jugular bulb, but certainly you want to skeletonize the jugular bulb, because one disadvantage of this approach compared to the retrosigmoid is your view low in the CP angle is not as good. So you have to work to improve that view, and that really involves working around on the jugular bulb. And with all of these cases, you really want to understand where the draining veins are. You're going to protect all of the veins during the operation. The next step is to really understand the CT in these cases, and that particularly you're looking at the pneumatization of the bone. So if you have a very pneumatized petrous bone, then you're going to find the drilling a lot easier, and of course you have to be careful, but it's usually a lot easier than if you have a much more solid bone. Occasionally you'd use this when there are intraosseous tumors invading through into the petrous, and then understanding the bone invasion when you're going to get onto bleeding. All of that is very important. The next important point, of course, is hearing, because as you'll all be fully aware, you can protect the hearing by going pre-sigmoid and going retrolabyrinthine. But if you go translabyrinthine, or the next extension transotic, then you're going to lose hearing the moment you enter into the labyrinth. So if you're looking to preserve hearing, and that is important, then we're really looking for a retrolabyrinthine approach. Then when it comes to counseling the patients, it's important to look and see what their preoperative clinical condition is. And I think this is where these tumors are different to a lot of other skull-based tumors. So with a lot of skull-based tumors, say if you take planar meningiomas or angiophossa tumors, although we say to patients it's really about stopping them getting worse, actually you expect them to get better. You know, with careful technique, you decompress, you open the optic canal, take tumor out of optic canal in juxtacellular meningiomas, you expect the vision to get better. Same with some of these lateral petrous meningiomas, they have trigeminal neuralgia, things like that, you expect them to be better postoperatively. I think for some of these cases that is different. So I've shown a picture here of a petroclival where the pier is involved, cyst within the brainstem. I think here it's hard to make the patients better in these sort of cases. So I think here it's very important to make it clear to patients this is about stopping them getting worse. And I think the biggest predictor of how they're going to do in these cases, which are different to other skull-based cases, is what they're like before the operation, and your aim is to keep them as well after. And I think it is difficult to improve them in these cases and using these approaches. Then there's a question about what you're going to face during the operation. Now, I agree that particularly with vestibular schwannomas, as Emad was saying, that the larger the tumor is, preserving hearing things becomes much harder. For some of these tumors that are in front of the brains, these sort of tumors that we're talking about here, I think some of the other factors are much more important than the pure size. Yes, the larger tumors will take longer, but actually the other factors that I've listed here are much more important. And tumor consistency is probably one of the biggest factors. So with soft tumors, you can get excellent resections. You can really work the tumor away from the brainstem nicely. They're nice, usually nice planes, and get a very good resection. But with very tough tumors, and if there's a poor plane with the vessels, particularly the brainstem, cranial nerves, you're in for a very, very difficult day. The other thing, of course, is the vascularity. So this is an example of an extremely vascular tumor, schwannoma, that we did, and the vascularity really matters and will slow your progress. So for me, I think the plane, the consistency, the vascularity really matters. Size is important, but I think that's a much smaller factor for me. And these are important points when you're counseling the patients about what you're expecting to achieve during the operation. Okay, so we're going to do this. A lot of these times, although I'm not going to talk about it today, but a lot of times when we're using these pre-sigmoid or petrosectomy approaches, we would combine it with an anterior petrosectomy as well. And so you want a good size incision. It allows you to go, if you need, retrosigmoid as well, but usually, you get to the posterior petrosectomy, but you can also do an anterior petrosectomy with this sort of incision. I like to do it park bench. I find that the seating position is very good, but I like the sort of lateral park bench position. Now, these are the different sort of approaches that we're talking about here. You have the pure retrosigmoid approach, the real workhorse approach, excellent approach, very, very useful. And a lot of people would take on a tumor like this that way, and I think that's very reasonable. But today we're talking about approaches going through the petrous bone here. So either going retrolabyrinthine through the labyrinth, that's translabyrinthine. The transcochlear approach is not really used anymore. That's an approach where you would mobilize the facial nerve and you get a very high facial nerve palsy rate, and really is not an approach people use. There is a transotic approach, which if we have time, I'll talk about briefly, where you drill the cochlea, and in some cases we find that helpful. But this is what we're going to talk about today. We're talking about, you could go retrosigmoid, as you heard from the last talk, but this is now becoming pre-sigmoid through the petrous bone to take you much more further anterior and around the front of the brainstem. Okay. So this is what the operative view would look like. So we are now on the left-hand side of the patient. Okay, left-hand side, we've made an opening. We've got middle fossa dura exposed here, posterior fossa dura at the back here, sigmoid sinus, and we're going to start the drilling to take away in this pre-sigmoid area. Just for orientation, this is the external ear canal. You'll do some of the bony drilling here. It'll take you down towards the cochlea, and the descending portion of the facial nerve we've started to expose, coming towards the stylomastoid foramen. But the malleus there, indicating the first genu, superior semicircular canal with the second genu. And this is sort of anatomy if you decide how much you're going to remove depending on your type of tumor. And I've just sort of drawn out in the same picture the various bits here. Okay, so these are your retrolabyrinthine air cells. These are your retrofacial air cells. Jugular bulb is going to be down there. And you have to decide if you want to preserve hearing, in which case you will drill retrolabyrinthine. If you want more exposure, you want to come further around the front of the brainstem. And we've drawn out the semicircular canals here, so you're going to drill translabyrinthine. Or if you want to get to the ascending portion of the carotid, which is useful in some of these tumors, I think that's a very difficult place to get to, either endoscopically or open. And then you would drill transotic. The one approach that we would never really use is transcochlear, where I said, you transpose the facial nerve. We do not use that approach. Okay, so it's either retrolabyrinthine, translabyrinthine, and can add a transotic, and we normally add an anterior petrosectomy as well. The next step, as I said, is cutting the tentorium. So this is, again, left-hand side. This is posterior fossa dura. This is middle fossa dura. This is the sectioning of the tentorium. I like to use coagulation. I don't use clips or anything like that. This is the labyrinth, so we're showing a retro-labyrinthine approach. The superior petrosal sinus here, I'll just go back. The superior petrosal sinus there has been coagulated. Then I'm going to cut through it. We've drawn it a bit big here, but vein of Labe, which should really be further down here, but vein of Labe is shown in the picture and must be protected. So we would advise doing after the drilling, which I'll show in a minute in a video, we would advise doing a T-shaped incision, a horizontal incision in the middle fossa dura, an incision vertically or craniocaudally in the posterior fossa dura. It's important to aim your incision towards the jugular bulb, because that is an area where your view can be restricted, and we can discuss it as time, some of the techniques for improving the view down there. You're then going to coagulate the superior petrosal sinus and then section the superior petrosal sinus and section the tentorium all the way to the tensorial incisura. You have to watch for the fourth nerve, but the fourth nerve is usually very anterior. And in this approach, unlike some of the other approaches coming from the middle fossa, it's actually very safe in terms of the fourth nerve. But you have to, obviously, whenever you're cutting the tentorium, you're always thinking the fourth nerve. You're always looking to protect the vein of Labe. And this is the kind of view you're trying to get inside. And the big difference here, well, there are a few big differences compared to the retrosigmoid when you do this pre-sigmoid approaches. And one of the big differences is you're much further forward, is the first thing to say. You're much further forward, you get onto the cranial nerves much more easily. The other thing I find incredibly helpful with this approach is you got the very wide corridors on either side of the fifth nerve, which you don't get unless you cut the tentorium. This is just an intraoperative picture showing the trigeminal nerve. And you can see this is the cranial, this is caudal. You just have this massive window here, which is very nice for working on tumors that are cranial to the fifth nerve. This shows an opening into Meckel's. So the corridors on either side of the fifth nerve are very nice. This is the fifth nerve, this is the seventh nerve, this is 9 and 10, and this is sort of the view you would get. The other thing you get is this angle going downwards to work downwards and clear tumor in front of the brainstem, and you're much further forward, as I said, compared to a retrosigmoid, which is very nice. Okay, so let's just, so we're going to watch the video again. This is actually a transaortic approach, so we're going to drill the labyrinth away, all of the retrolabyrinth area, and drilling down here towards the cochlea. We'll skip the bit where we did an anterior petrosectomy as well. So we'll just start that. This is left-hand side. So this is the bony canal, the external bony canal drilling there. I do this in combination with my ENT colleagues who are very good. Here we've drilled into the cochlea, not a standard part of our approach normally. It's a basilar membrane of the cochlea. It's done with the ENT surgeons. But because it's transaortic, we're now drilling the labyrinth away. Semicircular canals are being drilled away to get that translabyrinthine. I'll just pause it here nicely. It's a nice view. So just to reorientate you again, this is sigmoid sinus, middle fossa dura, posterior fossa pre-sigmoid dura. Jugular bulb will be there. We're starting to see it. You want to skeletonize that more. You'd want to drill medial to the jugular bulb. If you want, you can lower the jugular bulb. This is the 7th and 8th cranial nerves in the porus, and you have your superior and inferior gutters. In a translabyrinthine approach, that's very important, getting all the way around. For acoustics here this is different, although we've done it anyway. And we're going to make our incisions along here in the middle fossa dura, here in the posterior fossa dura. We're also going to coagulate and then section the tentorium. Descending segment of facial nerve here. So we're just going to go forward now. I'm sorry, I'm just going to skip. These are the anterior petrosectomy bits, which I will skip. Okay. So we're now cutting posterior, sorry, that was middle. This is now posterior fossa dura. It's being sectioned. We've opened middle fossa dura. The view has changed. I'll just pause this again so people can understand what's going on. This is middle fossa cut. This is the posterior fossa incision. I've just got a bit of Liar step to protect over the sigmoid sinus. This is the superior petrosal sinus that we're coagulating. I don't like using dural clips. I think coagulating is better. Some people would even cut out part of the tentorium. I think that's very good. We've coagulated the sinus. We're now cutting the tentorium. Nice view inside. This is the trigeminal nerve, suprapetrosal veins, distal SCA branch here. We're cutting the tentorium. We're looking to see where the fourth nerve is. The fourth nerve is usually much more anterior, and it's very safe. So we're sectioning the tentorium. I think in the interest of time, I'll just show the final sectioning of the tentorium. Unfortunately, the view gets a little bit less clear because I angle the scope to be really sure about the fourth nerve. So I've just done here. That's the final cut into the tentorium. Now I'm very clear that the fourth nerve is safe. It's usually much more anterior, the fourth nerve. And you just get this fantastic window. You can see this is the trigeminal nerve. You can see how you can work on either side. I really liked Emad's dissection. I like to use the bipolar and suction, but also peel on the arachnoid. But I use the bipolar and subtle to work between the two. I think it's a bit more efficient. You can see a nice arachnoid layers, tumors coming off the brainstem very nicely. I'm going to skip forward here. You have tumors coming off the brainstem very nicely here. See this fantastic view you have coming around the front of the brainstem. This is the fifth nerve. 7, 8 are here. I think in the interest of time, I will skip forward. We're just working on the tumor coming out nicely. Just to show you, this is the view towards the end. So this is, so I'll let it play. That's the lower cranial nerves there. 7, 8 is here. Tumor is nicely cleared off the brainstem. You can see the basilar artery. You can imagine using this approach of basilar artery and its branches if required. Coming here over the fifth nerve there. And you get a very nice view going nicely above the fifth. That's the fourth nerve going into the tentorium. But you'll see all the way up into the, these are the vessels around the midbrain. Okay. So I'll just move forward on that. So with even with very large tumors like this, you get very nice resections. Patients are importantly neurologically intact postoperatively. This is the patient here. She and her sisters ran a half marathon to raise money for our department afterwards. So she's in better shape than me after the operation. I think that's important. And you can combine it with other approaches as well. So this is a tumor that a lot of people I think would have gone endoscopically, which is fine. I prefer to combine it with this sort of transpetrous approach. You can see it's a complex but soft tumor, which makes it more straightforward, involving the cavernous sinus, towards the brainstem. So I combined that with this approach that I just described. You can, if you want, you could of course go on through the cavernous sinus, but I didn't do that. I combined an endoscopic approach with this approach, and you can see you get very nice resections using these approaches. Unfortunately left a small amount of residual there, but otherwise a good resection, and this patient is intact and doing very well from their chordoma. I'll just briefly mention the transotic approach for people maybe a bit more advanced, but this is what the picture we saw earlier. This is the descending facial nerve. Obviously the view you get inside the brainstem. This is the ascending carotid. This is an area that's very hard to get to both endoscopically and open, but actually by drilling out to the transotic approach, you get in there quite nicely. You can remove tumors, particularly chordomas, all of that from there. Okay, well, thank you very much. Obviously, this is a team effort. I've listed lots of people here in our team, particularly Sam McKeith, who is who's my ENT surgeon who works with me on the lateral skull base side. I've got other neurosurgery and ENT colleagues, and Rahul Shah helped me a lot with the pictures and the editing as one of our residents. Thank you very much.
Thank you, Sanjeeva. It was extremely didactic, and you showed us which are the gaps, which are the indications, which are the limits, and how you manage with this approach. And we have several questions, and Serge is asking you what happens if intraoperatively suddenly you have a damage on the vein of Labe. What should be your next step?
Okay, well, unfortunately, at that point, things are a bit late, I think. So there's lots of tricks you can use to protect the vein of Labe, which may be the more useful. First, you have to identify it. I think it's Ernest Niemeyer who described this very nice technique. You can put a bit of Surgicel and Tisseal on it to keep it a bit stronger. I don't use retractors, as you probably saw there. So there's no issues with retraction and trying to pull on it. I think once it's damaged, what can you do? There's not a lot you can do. You can try and pack and try and preserve its integrity if you can, but I think a lot of the focus has to be really on protecting it, identifying where it is, trying to make it stronger. There are tricks you can use with Tisseal, Surgicel, things like that, to prevent that from happening. Extremely unforgiving vein, as we all know. Imad's putting his hand up. He might have a technique.
Yes. Look, usually in these cases, when I use the pre-sigmoid approach, including the modified Hakuba, I call it, because I extend it sometimes more forward. I'd like, if there is some borderline hydrocephalus, I'm operating on the left side specifically, I like to put in EVD because it makes the temporal lobe much relaxed, and then you have a control on your retraction. You are minimizing your retraction very much by doing this. So this is a small trick I have been doing for the last couple of years, and I found it is very helpful. And this is a temporary, you can always take it out.
Any other comments from the panelists?
One comment as well, I think Dr. Sanjeeva mentioned, which is very important by doing this approach. You have to take the bone and go all the way down almost to the jugular bone. Because if you don't mobilize the sigmoid adequately, then you are not getting benefit from this approach. So you have to go down to mobilize that dura posteriorly with the sigmoid sinus. And the other things I'll do, other than coagulation, I don't trust coagulation on that petrosal sinus, to tell you the truth. I like to ligate it. I do ligation, double ligation and cut in between. It's very, very safe and simple procedure. But I'm always concerned about the vein of that superior petrosal sinus. But it's a nice approach, as you said. Once you do it, you spend time, but then you have open door to the most of the skull base. From cranial nerve, even you see the tract of the optic down to 11. It's a fantastic approach, but it's time consuming and the drilling amount is much. And Hakuba has published taking the semicircular canal and skeletizing only the bone and leaving the membranous. But these people, from the 8 cases they done, they lost hearing in 4 of them. So you don't want to replace a case where you can maintain the hearing, because this case, like the one you showed, the big petroclival meningioma, perhaps she's still having hearing, isn't it? She is not vestibular schwannoma. And you
yes,
don't want,
correct. So in those ones, we look to go retrolabyrinthine. I agree. I think the moment you start drilling at the labyrinth, it's hard to protect hearing.
Yeah.
So we look to, if they have hearing, we look to go retro lab for it. And with the jugular bulb, just to come back to that, it's not just, you're quite right, we should expose it, but also you have to drill medial to it to really get the space.
And I want to ask Henry, because that case of chordoma, you mentioned the endoscope. I'm more inclined nowadays when I see chordoma, midline, purely midline, I will go for the transfemoral surgery or transoral surgery, whatever, with the endoscope. It's a fantastic because you are directly on the lesion and you take a good amount without all these conventional, I call it, we used to do all the complex approaches to far lateral and to go to these lesions. But the purely midline clival lesions, I think this is a primary indication for endoscopy. Do you agree to this, Henry?
Yeah, I agree.
What's your opinion?
I think this case was an ideal case for purely endoscopic because it was not far lateral. So I think with a 45-degree endoscope, and we have even a curved bow, diamond bow, where you can really go to these areas and you can drill the bone away, which is infiltrated, I think, for the medial ones. But I would just want to make a comment to the pre-sigmoid approach. In Germany, most people have abandoned to do it. In the case what you showed, I would try a retro-sig. Of course, the angle of view is not the same like a pre-sigmoid, but the risks are larger with the pre-sigmoid approach. And even Sami said in most of the cases he has abandoned this approach. And also Seifert, he switched completely to retro-sig for the petroclival meningiomas, at least for most of them. And if you have a blind corner, we use endoscopes like Imad has shown, and you can look in the frontal area of the brainstem. You can look to Meckel's cave and other areas.
No, I think retrosigmoid, and that is a work. Most of these cases we would do retrosig, but I think for me, it shortens your working distance. You're much closer. For some of the more difficult tumors, I really like it, and I think it's very nice. But you're right. You can drill. You know, you can do a reverse Kawase. You can cut the tentorium. There's lots you can do. Retrosigmoid, they can give you that view without the drilling. I don't think the risks go up except for hearing. You know, the drilling is not that complicated.
Sami reported some venous problems when he cuts a tent and he coagulates the superior petrosal sinus, and incidentally there was some problems with the vein of Labaine, and this really may cause major problems.
And we haven't seen that, although we study the venous supply very carefully pre-op. But you're right, it theoretically could happen, definitely.
That's what is mentioned in Hakuba's and Ohata paper. That's why they studied the venous system, because even not touching the Labaine vein by itself, the petrosal vein can be a catastrophe if it's the major draining to the system.
Yeah.
And sometimes you never predict it unless you do a good MRV and you study it well, as you mentioned.
Yeah, I think it's very important, because in microvascular decompression, we see so many variations. Sometimes you have 3-4 big veins and you think the whole cerebellum is draining via this petrosal vein complex. And sometimes it's just a minor one. It's very variable. And that's what you also mentioned. It's very important. We have to look for each case very carefully at the MR images. Yeah.
No, I agree fully. And we're very lucky. We've got very good neuroradiologists that really help us with that. So.
Yeah.
Well, I have something to say, Sanjeeva. Well, the pre-sigmoid approach, I think we have done it, and you know, the drilling itself is 6 hours to 7 hours. If your ENT colleague is doing it, fantastic. But if you are doing it, you don't want to get on a tumor completely tired and drained. So the best way for me is an anterior petrosectomy. It is about 2 centimeter to 3 centimeter incision. And then you do an anterior petrosectomy, you devascularize the tumor, and you're cutting the superior petrosal sinus way anteriorly. This is much more safer than cutting it posteriorly. The only problem is you have to visualize the fourth, and then at the fourth, you have to go a little bit posteriorly. And if you do that, your access to these petroclival tumors is very easy. Otherwise, you'll be sitting and doing. I remember a live case in India where I went and did this with Vinod, and we ended up doing the tumor at 2 a.m., 3 a.m. in the morning. You know, it's a bit crazy. I mean, and it's too much effort for nothing. So if you start an anterior petrosectomy, it's much more easier. But I see that you have a good ENT colleague, so I guess it's all right.
Yeah, the only thing I mean, we were on a cadaveric course together where you demonstrated that very nicely, going very low with that. I think that's difficult to do, actually, what you described, getting very low with an anterior petrosectomy, although you went very low there, or maybe to the jugular foramen, I think. But I think for most people that'd be hard to do. And yes, you're right, I've got a very good ENT colleague, so I'm having coffee while that's happening. So.
Dr. Sanjeeva, Dr. Hakuba has described the combination, the pre and retrosig.
Yes.
And that's what we were doing. We're doing the pre-sigmoid, but we complemented with the retromastoid.
Yeah.
Retrosig approach. So it gives you access to a lower part of the posterior fossa.
I agree. And that is one weakness, seeing that very low bit with this pre-sigmoid approach. You are restricted by the jugular bulb.
But for the participant and for the attendee, they should go to the lab, learn all these approaches. Nothing comes from nothing. I mean, you have to learn something, and then you make the judgment how you will, when you need it, you know how to do it. And this is important. You learn the anatomy first, not live, but without the concern and the stress of vascular injuries or cranial nerve deficits. So using the lab and attend the masters while they are doing procedures, this is one of the recipe, like Halstead say, the best venue is the ward, the station. And for surgeon, the best venue is to go to the OR, watch these masters. We all did it. We all did it. I'm sure Professor Benish and myself, all of you were to one of these masters. We learn from them. We see what we can adapt and what we can get away from. And this is, I think, the message for the young people there. They have to attend this kind of surgery with the masters and go to the lab, do a lot of anatomical dissection.
No, absolutely. And although I have an ENT surgeon, I think it's really important you understand this anatomy, so you understand what view you can get, what they can do more for you. Same with the anterofossa endoscopy. I think we have to understand the anatomy as well as the ENT guys do. So you really understand where they can get you, what you can do with these approaches for complex skull-based lesions. I agree fully.
Pablo and Sanjeeva, you want to conclude this session, or you have still something you want to get the people to discuss something?
I don't know if you were checking the chat, but we had people from many countries, and the last 100 messages, they are all thanking you for your time and for being here, for your discussions. And I think we need to thank them for being there, because otherwise it's nonsense.
So we are going to conclude the sessions, and would like to thank the faculties that they were patient with me, with my correspondence, and they stayed long beyond the assigned time for today. And of course, the participants, they are the most important. We need their feedback, and I hope there will be some kind of evaluation from their side, how we are going in the future, because we have the plan, Professor Benish and myself and the team, to continue this as a dynamic course. But it seems this is the trend now, not only one-time events. With the COVID-19, and perhaps even in the future, it is less costly for the trainees, no traveling, and they are getting this, and we hope it will continue to be free as we planned it. And we will continue next month. We'll assign the day, we'll announce it, and there will be dynamic changing the lectures, modifying speakers, they can change the topics, but we need the feedback. Without the feedback, and you mentioned it, Pablo, we have a positive feedback, but from the 2,500 registered, we'd like to have some kind of an informative statistic, how we will go for the next plan.
Tomorrow, once we conclude, we will give them a website where they can fill up a
feedback
app, and we will be informed, and then they will be able to get the certificate also.
I'd like to ask Vladimir, is he with us?
Yeah,
Vladimir, you want to say something, please?
No, thanks to all. Thanks to the faculty, thanks to the attendees. And Pablo, thanks to you. That was great.
And Sanjeeva.
I think that we shall meet tomorrow at the same number. What was the number, Pablo?
Well, it was difficult to measure because we were here 500. That was the limit for Zoom. We are trying to increase it by tomorrow, but there were like 400 in YouTube. I don't know how many with Neurosurgical TV, so maybe 1,500, something like that.
Great.
Aipe, I want to say hi for the nice lady behind you. She is the master in table tennis.
Alona.
You should change the spots, you know. I'd go to the background.
Hi, Alona. Nice to see you.
Nice to see you.
And Momos,
we would be happy to be on your farm, Ibe.
Yeah, anytime.
All of you, I am missing all of you guys, everybody.
We don't have to do an online course in